Good morning and welcome to a new episode of Nature Returns, Investing in Ecosystem Services, a webinar series hosted by the Yale Center for Business and the Environment. My name is Olivia Sanchez and I will be your host for today's presentation. The Nature Returns webinar series addresses the growing importance of ecosystem service valuation and investment. And today we're kicking off our third webinar in this series related to ecosystem services and human health. So a few weeks ago, we had one with EcoHealth Alliance on the quantification of health costs of infectious diseases emerging from deforestation and land use change. And just last week, we had Restore the Earth Foundation, who joined us to present about their ecometrics model. So each presentation is recorded and available on the CBAE website through YouTube and iTunes as well. So you can check those to re-listen to all past webinars, as well as this one that we're having today. So today we're having a discussion about the business case for investing in green infrastructure, namely parks and other green urban areas. There's a growing body of research that shows the connections between exposure to nature and physical, social, mental, and community well-being. And our guests today will explore this from a public health expenditure lens. So joining us today, we have Kathryn Boyle and Dr. Stephen van Den Eeden from Kaiser Permanente and Dr. Matthew Browning from the University of Illinois at Urbana-Champaign. Kathryn Boyle has been a project manager with Kaiser Permanente Northern California Region Community Benefit Programs for 10 years and has been working in place-based funding initiatives to improve public health for more than 15 years. Kathryn manages the Healthy Eating, Active Living, HEAL portfolio of grants that foster healthy behaviors, including a park portfolio of over 2 million. In addition, Kathryn supports the implementation of Kaiser Permanente's Thriving Schools initiative in Northern California. Dr. van Den Eeden conducts etiologic and outcome studies in cancer, neurodegenerative diseases, and benign genitourinary conditions. He's a founding investigator on the California Men's Health Study, a prospective cohort study of over 84,000 men, and leads the environmental exposures core for the research program in genes, environment, and health. And finally, we have Dr. Browning, an assistant professor at the Department of Recreation, Sport, and Tourism at the University of Illinois at Urbana-Champaign. His primary research revolves around the physiological responses to virtual environments and spatial relationships between green space. For instance, he is now testing how 360-degree videos of nature in virtual reality settings influence stress recovery compared with actually sitting outdoors in nature. So before we start, I'd like to remind our listeners that there will be 15 minutes for Q&A at the end of the session. Throughout the webinar, you can type your questions in the Q&A section at the bottom of your screen, and then we will pose them to our speakers at the end of the presentation. So without further ado, I'd like to pass it on to Kathryn. Kathryn, the floor is all yours.
Thank you very much. Thank you for the introduction, and I'm really delighted to be here on this panel, virtually presenting to you and sharing with you Kaiser Permanente Northern California Region's commitment to parks and open spaces. Let me sorry, I'm getting a little bit of control here. Okay, so first of all, to understand why Kaiser Permanente is involved in this work, it's helpful to understand a little bit about the history of Kaiser Permanente and our approach to healthcare in general. So for those who aren't familiar, Kaiser Permanente is a nonprofit integrated health plan and hospital system. We have over 8 regions throughout the United States, 38 hospitals, over 11 million members to whom we provide healthcare services, over 21,000 physicians and nearly 200,000 employees. So it's a large system throughout the country, but in very specific regions, so not everywhere across the US. From its inception, Kaiser Permanente's total health approach acknowledges that healthcare is just one part of the health ecosystem. Individual and community health, which we define as mind, body, and spirit, is driven by many factors, including social, economic, and environmental influences. This approach is embedded in our mission, which you see here, which is to provide high-quality, affordable healthcare services and to improve the health of our members and the communities we serve. One of the ways we operationalize this is through our community benefit investments, which is where I am. I'm in our Northern California Regional Community Benefit Programs Department. And our total investments in 2015 were over close to $900 million in Northern California. Oh, sorry. Okay, so our community benefit investments are determined through the Community Health Needs Assessment process, which is a national requirement of all nonprofit hospitals to review local primary and secondary health data and determine priority health needs for the community. This slide lists the top health needs identified across our region that will guide our community benefit investments in 2017 through 2019. So our top priority needs are healthy eating, active living, community and family safety, mental health and wellness, access to care and the safety net, and economic security. Throughout this community health needs assessment process, we also identified that a common strategy increasing access to safe parks and public spaces was at the intersection between healthy eating, active living, community and family safety, and mental health and wellness. And as with all our community benefit investments, we focus on geographic areas of high disparities within our Northern California community service areas. And we also emphasize policy, systems, and environmental change for greater sustainability, as well as evidence-based, high reach, and impact strategies. So within the realm of evidence-based strategies, parks and open spaces and the commitment to nature fall well within that criteria. The following several slides, and I know the panelists after me will get more into that evidence base, but just to provide a high-level overview of the many benefits of investing in parks and open spaces. There are the physical benefits, many of which are listed here, including healthier body weight, stronger bones and muscle, the restorative nature of nature and open spaces in general. Time in nature also has multiple mental health benefits, including stress reduction, increased energy and alertness, and reduced depression and anxiety. Time in nature has educational benefits for young children, including developing their individual skills and capacities, as well as learning to be stewards of the environment. And there are many benefits to the community in investing in parks and nature, including increased social and neighborhood cohesion, positive youth activities that reduce crime, environmental stewardship, as well as increased property values and community investment. So based on this evidence and the recognition that there are significant disparities in parks usage by ethnicity, age, and gender, as well as inequitable availability of parks and open spaces throughout our Northern California geography, we developed our parks framework to support greater equity in access to and usage of parks. We organized our framework around policy, programs, and infrastructure. By policy, we are referring to public policy, which can include things such as advocacy to support funding for parks or parks master plans. It can also include organizational policies, such as how parks institutionalize their practices to be relevant and culturally appropriate to the communities they serve, such as staff hiring and training practices and their collaboration with other community organizations and partners. Programs are called out to acknowledge the importance of providing extra support to ensure that programs are designed to meet community needs and to encourage non-traditional high-need populations, such as at-risk youth, communities of color, low-income communities, and seniors to utilize parks. Infrastructure within our framework refers to actually building or enhancing parks and public spaces, particularly to narrow the disparities in communities with few or no parks or open spaces. Our current parks portfolio of investments represents the three areas within our framework. This slide depicts many of the organizations that are currently part of our $2 million parks portfolio. In addition, our general work in communities currently and over the years has featured parks. For example, our HEAL or Healthy Eating Active Living zones are place-based investments that are seeking to implement multiple strategies to create healthier places for high-need communities. Community residents especially have gravitated to opportunities to create places where families can be active and congregate. They have worked with their cities and community-based organizations to build better parks and public places and build programming for those parks to maximize the benefits they provide. So a few examples of the impact of our investments. Primarily, we're seeking to increase the number of park visits and opportunities for outdoor physical activity among high-need populations. So within the infrastructure realm, just over the past years, we've realized multiple impacts and benefits. We were able to build 3 new play structures with shade and adult fitness equipment in partnership with Kaboom in 2016 in Modesto, Stockton, and Fresno. And there are 3 to 5 more parks coming online this year through our investments. We're supporting the Magical Bridge Playground in Redwood City, which provides a safe and welcoming space for children with special needs. And we're supporting the Green Schoolyards Initiative in San Francisco with the Children in Nature Network. Programmatic impact includes the Healthy Parks, Healthy People Bay Area initiative that includes over 50 park organizations working to provide culturally appropriate programs to introduce non-traditional park users to parks. And grants to organizations supporting at-risk youth in the outdoors, coupled with a learning community to build capacity to provide quality outdoor experiences for youth are among our investments. In the policy realm, we're supporting Parks Master Plan development and a pilot Parks prescriptions program in Fresno. And we've supported the development of a complete Parks playbook, which was developed to help jurisdictions assess their communities' park systems and determine areas in need and policy levers that can facilitate those improvements. So finally, we see the future of our investments of this work is to continue to build at the intersection between parks, public spaces, and safety for the benefit of physical, mental, and community health. Up to this point, we have largely focused on parks. We know, though, that other types of public spaces and access to nature may be more accessible and relevant to communities, particularly low-income communities of high need. There are many opportunities to develop green spaces or community gathering places or resident-driven beautification projects that contribute to community safety, neighborhood cohesion, social and emotional health, and family resiliency. That's the end of my presentation. My contact information is here. I'm happy to speak with anyone offline if they have any questions about this, and I know there'll be an opportunity for questions later. So thank you for the opportunity to give an overview of our investments in parks and open spaces.
Thank you, Kathryn. So for those of you just joining us, Kathryn Boyle from Kaiser Permanente has just presented on Kaiser Permanente's evidence-based reasons for investing in equitable access to nature, including examples from Kaiser's 2.1 million portfolio in access to nature through infrastructure, programs, and policy. So next, Drs. Stephen van den Eeden and Matthew Browning will outline a recent study and partnerships between academic institutions and Kaiser, linking satellite data on urban forests to individual level health outcomes and costs. And we'll discuss the returns on investment expected from various investments in urban forestry. We have many interesting questions coming in. So again, you can type them in the Q&A chat window and we will begin addressing them in about 25 minutes. Matt, welcome.
Thank you, Olivia. So I'm going to be talking about our ongoing project, which looks at whether nature, and in particular residential green space, reduces how much people spend on healthcare. This project is led by our Parks and Environmental Behavior Research Group, which is an interdisciplinary group of scholars across the University of Illinois at Urbana-Champaign, as well as Kaiser Permanente, the Northern California Division of Research, where Stephen is housed. The current project is supported by the U.S. Forest Service National Urban and Community Forestry Challenge Cost Share Grant, but it's also supported by 16 organizations beyond Kaiser Permanente and University of Illinois contributing in-kind services. The current project is anticipated to run through 2019, but we anticipate trying to replicate our methods in a different region of the country to see the generalizability of our results. One of the main reasons we're doing this project is because of the astronomical increase in healthcare costs in the United States. You can see that the rise in healthcare costs in this country is much more than other OECD countries, and we are approaching $9,000 per person per year on average. And this spending is not just from employer-sponsored healthcare, but it's also federal-sponsored healthcare, such as Medicare. You can see the Medicare budget there in combination with Medicaid is now as much as the national defense spending by our country. This is from 2016. It's not the current spending, but we are now spending as much federally on healthcare as we spend on defense. Simultaneously, the effects of nature on health are huge and represent a great opportunity for nature to serve as an adjunct treatment for many physical and mental health illnesses. I apologize for my grandfather clock going off there in the background. Um, this is an example of forest bathing in Japan, which is becoming increasingly popular. Some of the effects of this has been shown to cause reduction in stress hormones and increased activity, positive activity in the immune functioning in as little as 5 minutes of walking in a forest setting such as this. And because of these huge, quick effects from nature, we see that there's great impact on a variety of different health outcomes of interest. Anything from anxiety disorder to cancer, childhood obesity, coronary heart disease, depression, diabetes, immune system functioning, mortality, and the common cold. When we extrapolate this to the annual costs of these health outcomes, we can see that increased exposure to nature may considerably reduce how much we spend on healthcare spending. This was a recent literature review and estimated healthcare cost spending or savings from one of our colleagues, Kathy Wolf at University of Washington. You can see that the effects can range in the billions of dollars saved if we use nature as an intervention for health. One of the interesting questions is, why is nature potentially so beneficial? And there are a few theories that have been around for decades, but there's most likely a number of different mechanisms between exposure to natural environments and human health. In fact, one of our investigators on this project, Dr. Ming Kuo, here at the University of Illinois, her picture is in the upper right, I apologize, recently published a literature review in Frontiers of Psychology, which has identified 21 possible pathways between nature exposure and human health. And these include the 3 boxes on the left: ingredients from nature, physiological and psychological states, and conditions and behaviors. So exposure to nature includes certain ingredients such as antimicrobial phytocides, beneficial bacteria, even views and sounds of nature. These can influence our physiological and psychological states, reducing our stress, reducing rumination, restoring our attention, eliciting a sense of awe. They can also lead to beneficial health conditions and behaviors such as better sleep, more physical activity, increased social interaction, etc. And what our colleague, Dr. Kuo, suggests is that all of these may actually in turn lead to a central pathway, which is nature exposure increases our immune functioning because immune functioning is tied to many of the health outcomes we see in these studies. A third reason why to do this project is because of the vast difference on how much we spend on healthcare and how much we spend on parks. And certainly, Kathy, I very much appreciate Kaiser Permanente's work supporting a lot of the programming elements going on in Northern California. Nationwide, however, we see that there's a big difference. Cities, a recent study of 100 US cities found that parks and recreation departments were spending about $83 per person on parks. In contrast, as I mentioned before, we're spending about $8,000 to $9,000 per person per year on healthcare spending. So we're spending about 100 times more on our healthcare costs than we are on parks, despite the fact that, as you see, one of the outcomes here is physical activity, despite the fact that that physical activity is probably costing us $60 billion per year. So there's a great discrepancy and a great opportunity to increase urban greening to improve our physical and mental health. There's never been a study that has objectively looked at healthcare costs and an urban green space around where people live. And so this project is the first one to do that. We will also be looking at actual healthcare savings and looking at objective measures of urban green space rather than, for example, perceived access to parks. The first aim of our study is to draw an association between urban forests and healthcare savings, with the likely explanation, if we do find that relationship, that there may be a cause and effect relationship. So we'll look at healthcare spending in very low green neighborhoods, such as the one on the left, compared to very green neighborhoods on the one on the right, and everything in between, and control for a range of sociodemographic, environmental factors, and look at the influence of green space on healthcare costs. We'll also be looking at dose response curves such that if neighborhoods with similar sociodemographic characteristics have more or less green space, does the effect, is it a linear effect or is it a different relationship? Is there some sort of maximal dose curve such that we can, plant some level of trees where if we plant more trees than that, we're actually decreasing the strength of that relationship? And some literature actually suggested about 25% canopy cover along a street may be the optimal amount for at least perceived stress reduction. We're going to be looking at with objective healthcare costs. We're also going to look at dose response curves in regards to proximity to parks. So Presidio here in northern San Francisco, right next to the Golden Gate Bridge, is next to residential neighborhoods, and so we can look at, while controlling for those sociodemographic environmental factors I mentioned earlier, whether there's decreasing effects of that green space as you get farther away from the park. We also have the opportunity to conduct longitudinal analyses because we have these healthcare costs over 20 years. And so we can look at whether the costs are decreased after a community has invested in urban greening. And similarly, we can look at individuals within our data set that have moved throughout the course of those 20 years and whether they're spending less on healthcare after they move to a greener neighborhood. And if so, when do you see that effect? The second aim of our study builds off of some work from the Netherlands that suggested 50% of the health disparities we see in low income versus higher income individuals is explained by access to green space. So we'll be able to split up our sample and see whether those findings hold with in Northern California with healthcare costs. Those data we're looking at mortality rates, so we'll be looking at a different outcome. The third aim, which is quite novel, is looking not just at presence or absence of green, but actually different types of green infrastructure. So to what extent do a series of small street trees versus sparse, very large trees versus parks with stratified tree canopy versus parks with grass and canopy trees underneath contribute to healthcare costs? And we'll be able to do that because we're using high resolution remote sensing data, LiDAR, which is collected from a low-flying airplane that shoots down these laser beams and records the rate of return back to the airplane. And it's actually able to map out in 3D, as you see here, the heights of different structures and classify those based whether there's some sort of vegetation or a building or a paved surface. And so we're actually be able to differentiate different urban forest types with this data set. Now, LiDAR is collected normally once for a region. It's pretty intensive to collect. And so we'll be supplementing that data with coarser resolution but longitudinal remote sensing data set, which is Landsat. And you can see that Landsat is I apologize again. For some reason, someone's decided to use a hammer drill in our office today. You can see that Landsat allows you to look at changes in land cover classification over time. It's collected every year, such that we can see neighborhoods that have increased in green space and how that relates to healthcare costs. So Stephen, I will turn it over for you for the next few slides.
Okay. So thank you very much. Thank you to the Yale Center and the group here. So I won't go over this. I will, since Kathryn did talk about it, but I did want to mention that one advantage of doing it within Kaiser, there are several, but one of them is it's an integrated system, as was mentioned. And what that means is individuals who are members of Kaiser get essentially all their care within the system, and we can capture that. And the other part is that this is a prepaid program, so that there's essentially no barriers to any individual getting care. So that becomes a factor that allows us to not consider that as a explanation for whatever results we obtain. And it doesn't seem to be moving on me. There we go. So this is the geographic area that we serve, and it's really quite large. It's actually larger than some 22 states in the United States. So I'll show you another slide later that gets to a little bit of the diversity that we're going to be able to use within the study. And again, I apologize. Oh, there we go. Okay, so Matt mentioned some earlier studies, and most of these studies are essentially two-step processes where they look at or try to estimate what exposure to the environment, or in this situation, green space, and specific health events are. Mortality or cardiovascular disease or things like that. And then they take that reduction and apply it to some external estimates of charges or payments. And these estimates sometimes come from various national data, Medicare data, and similar kinds of databases regarding costs. And most of those are charges or payments. And what we're seeking to do is link costs for the individual within a single system rather than doing it as a two-step. And I'll get into a little bit about our cost data in a second. There we go. Sorry, there's a little bit of delay in the transfer. So our cost data come from something within our program that's called Cost Management Information System. And really what we're trying to do is estimate the actual cost of services delivered. And these are quite different from prices or charges, which we don't need to go into, but are really not necessarily tied really to what it costs to deliver care. And this is a regional cost accounting system that we're able to estimate the cost by a specific facility, by a specific department, by a specific length of visit, by a specific procedure performed, lab tests. It includes inpatient, outpatient, radiology services. Also built into this is overhead costs, so the costs that it takes to keep your clinics clean with custodial services. So all of that's actually built in as well. I don't need you to read any of this. It's just to say that all of this goes into both creating the utilization profile for a single member over time, as well as being able to link these various systems into our cost data. This is a general representation. For HIPAA reasons, we've masked this, but it gives you the idea of where our members live. And within all of those areas, we have broad coverage. within urban, suburban, exurban, and certainly rural areas, where the factors that we're interested in this particular study, greenspace, has wide and varied distribution across area, across socioeconomic status, and that sort of thing. So, as I said, what we're going to be doing is in two separate efforts. The first is going to be led by Matt and his team to link or to develop the exposure data, i.e. the green space data for the whole geographic area. And then we're going to put together a linear file of everybody's residential addresses, and then we're going to link those two together, and then there'll be a third link to the cost data for individuals. So what we're able to actually take advantage of as well, and Matt alluded to this, is individuals who move will have the information in terms of green space at residence A and residence B, or how many other residents they have. Also included in this is pharmacy costs. This includes the actual cost of the drug, as well as the marginal cost it takes to have that drug on the shelf, as well as dispense it. We also include costs covered by non-Kaiser members or Kaiser providers. Occasionally we refer out for services that we don't have inside. We're able to get those costs, or if somebody has an emergency department visit somewhere that doesn't include a Kaiser facility, we're able to include those costs as well. And then this is an example of a hypothetical person and what it would look like, sort of file, and down the right side is the cost for each of those particular encounters with our health system. And then basically what we'll be doing is using, we don't have a lot of statistics in this presentation, but we'll be regressing the green space of each individual on their cost, or seeing how much the green space accounts for the healthcare costs after taking into account factors that are very important, like age, race, ethnicity, sex, socioeconomic status, things like that. And then, as Matt noted, one of our aims will be to look within each of those strata, just within women or just within certain race, ethnic groups, and see what that relationship looks like, because it could be, and there's good reason to suspect that it might be different by those various categories. And I think it goes back to Matt.
Thank you, Stephen. Yeah, so we have a fourth aim, and that is to generate actually nationally representative, scalable results, such that an urban forester in New Haven, Connecticut can try to model different urban forestry infrastructure development strategies. So making a new park, or planting another 1,000 street trees throughout the city, and model what the impact on healthcare savings for the entire neighborhood might be. And then based on those different scenarios, figure out which would be perhaps most effective for their health outcome. And the way we hope to do that is using an online open source platform, which is provided through the Natural Capital Project, which is a joint venture of Stanford and University of Minnesota, which allows policymakers and planners, as you can see here, to model different land cover characteristics, as well as pulling in census data, and then build these quite illustrative maps of, for example, recreational amenities, fishing amenities, coastal protection. They have a range of models that are currently available, so we hope to actually build one of these for healthcare savings based off of land cover classification, and then future scenarios for investment. We will obviously need to test this model in different regions of the country, as I alluded to earlier. So our findings from California will be, we'll build an initial model that we'll test later. Now California, we intentionally picked California in part because of our ability to work with Kaiser Permanente, but also California is quite diverse in regards to climatic zones, as well as demographic characteristics of the people living in the larger Northern California area. And so our ability to, as Stephen mentioned, segment the population into different strata is much higher than we'd be able to do in other parts of the country. We will be creating these graphical flyers that we'll be able to distribute at events, as well as provide free online. And one of the main goals of these is to provide them to, next slide please, to policymakers. And in fact, a major contribution of our grant is to work with the National Wildlife Federation and develop a policy campaign where they go to Capitol Hill and provide these flyers and that will talk about the results from this current study, as well as the accumulated research on the health benefits of nature in general, to convince policymakers and inform them about, strategically greening our cities. And some of our constituents. If you can jump 2 slides, please. One more. Yep, some of our constituents will be state legislatures, legislators, as well as some of the federal agencies and bureaus, as well as state agencies and bureaus, because oftentimes that is where the urban forestry efforts are strongest. So you can see a few of our vehicles of dissemination there. And if you can go back 1 slide. Yeah, so here's some projected graphs on what we expect to find. The figures, I apologize. So on the left, you can see we might find that healthcare savings per city block is relatively low in regards to below average urban forestry infrastructure, where it might be much higher when there's above average urban forestry infrastructure. For example, more street trees on that block. On the right-hand side, we're hypothesizing that street trees and parks independently contribute to healthcare savings. And part of that is, I mentioned there's these 21 possible mechanisms, maybe more. Some of that has to do with our physiological and psychological response to seeing nature. And some of it has to do with being physically active in these spaces or socially interacting, and those are independent effects. So you can see we're hypothesizing that if you have a park, if you're closer to a park, your health expenditures are going to be less. But then also, if you have street trees and a park nearby, those effects will be cumulative, and that's where you'll actually find the lowest healthcare expenditures. And there was a paper that came out a couple years ago looking at the number of street trees in Toronto and the health of residents there, and they actually extrapolated what the increased cost of living would be if you lived on a street with more street trees. And they were looking at about a 1-to-10 ratio, such that if you had 100 more trees, then people, and the cost of those trees were, say, $1 each, then people would be making about $10,000 more on their annual salary. That was the extrapolation they provided. And I'm just saying that because we're estimating a return on investment from these urban forestry infrastructures between a 1-to-10 or a 1-to-100 ratio. So the effects might be quite sizable. And you can jump forward. Yep, that's our last slide. I just wanted to provide an overview of all the people contributing to this project. We have many urban forestry groups that are providing data and cost estimates on how much these urban forests cost to maintain and plant. We also have groups that are quite well versed in geospatial analytics, such as American Cancer Society, as well as our academic institutions, which I would include Division of Research in. We even have groups overseas, such as the Paul Schreer Institute outside of Zurich, Switzerland, which is quite versed in these ecosystem modelings, which will play into these natural capital models. And that's my last slide. So I'm looking forward to our conversation now.
Thank you, Kathryn, Stephen, and Matt. That was really interesting to learn about Kaiser Permanente's investments and the ongoing study that you're working on. This whole body of work is quite exciting. So before we get going with the questions, I just want to remind our listeners that there's actually a Google Doc link in the chat window. If you typed questions before in the Q&A chat box, please retype them in the Google Doc, as there's some technical difficulties with the Q&A. So we'll be checking the questions straight from the Google form. So our first question is about causality and correlation. So you mentioned your track where people are coming from and like where people are moving to and from, but how do you know that any healthcare costs for one of these Kaiser members in the study are due to living near or far trees or green space? Are you also incorporating qualitative data from, for instance, focus groups or interviews to know how much access people actually have?
So I'll start out, and Matt, feel free to join in. We are not collecting data from individuals, in part because there's 4 million people, actually even more than that, because we're using some historical data. So, you know, there's probably upward of 5 million individuals involved. We don't know specifically that a specific cost visit to a clinician is due to the green space where they're going to be living. What we're doing is a population-wide study where, quite simply, or at least simple in concept, is that individuals who live in areas where there is a lot of green space have lower healthcare expenditures compared to those that live in areas with minimal green space. And what the trick of the study is, of course, is figuring out what are all the other factors that go into where people live and what their healthcare expenditures are, and taking those into account in our analysis so that we try to get as close to the truth as possible.
Great, thank you. Another question about this study is whether it will incorporate safety data such as crime or look at neighborhood boundaries as blocking access to green space. So for instance, someone living within 500 feet of green space but unable to access that same space because of safety reasons.
So so around that, it's some of that is a little bit more difficult because of the quality of data that are out there, the readily available. The easiest crime data, for example, that is able to be put together for our whole geographic area is at the county level, and that's probably not going to be sufficient to address the issue that was quite properly arranged. We might have ability to look in smaller areas for kind of a qualitative assessment of that issue, where crime data is available in a much better way. But that's going to be a concern and something we're going to have to work a little extra hard to address.
Okay, great. So now we have a question related to that, to actually this connection between, you know, human health and nature. So we have a question from a viewer in Kentucky who says that, he says, there are lots of rural areas and poverty in this state. My first thought is this is a population with extensive access to green space, yet their health challenges are quite similar to those in urban areas with no green space, such as adult and childhood obesity, diabetes, etc. What changes might a rural population in Kentucky make to get more out of the green environment, which is easily accessible to them?
I'll let Matt take that.
Sure. Yeah, it's interesting. Unfortunately, most of the larger scale studies and even some of the case studies are done in urban centers, and that really limits how we can think about how rural communities can promote healthy behaviors, for example, in green space. This study will be in both urban and rural settings, although most of the population, simply due to the urban nature of it, will be in more densely populated housing areas. So to answer your question, the science isn't actually that strong on it. There's some science suggests that the perceived access, perceived amenities, I'm sorry, of rural green spaces has some effect, such that if you have public lands nearby, or if you have private lands, but there's not an obvious trail structure to use those spaces, then they don't have much of effect. But the science is out on that question. Anecdotally, I could speak to some work going on, but it's I think further work is needed to answer that with any confidence.
Thank you, Matt. Now, this may be a question for Kathryn. There's a viewer who's asking more about the funding for green space. So specifically, are we thinking, or is Kaiser Permanente thinking of nature as an actual medical prescription moving forward? For instance, would prescribing nature be covered under an insurance, just like any other medication would? Or is it funded out of pools of money set aside for community benefits or corporate social responsibility purposes?
That's a really great question. Thank you for that. Currently, our investments are strictly from community benefit. And as I described, the reason for that, which is in statute and so forth, that we do community benefit, but also our commitment to the communities that we serve. I have heard that discussion amongst people who are in this field about, first of all, that parks prescriptions are a valid method of getting people out in nature and actually prescribing people to go do activities in nature, or just being outside and so forth. We have examples of that within our system. It's not systematized exactly yet, and I have heard the sort of optimal of having that be part of a regular model of our healthcare. That's actually something that's reimbursed. I think that's many years from now, perhaps, that we would be able to get to that point. But I think that there are visionaries who are thinking along those lines, and the stronger evidence that we have that there are healthcare cost reductions in doing that, I think the further along we would be able to get in that realm.
Thank you, Kathryn. Matt, relating to the regression you shared towards the end of the presentation, how were the specific healthcare and pharmaceutical costs selected for the regression? Were they based on literature review of health impacts, for instance?
Yeah, so we're going to be looking at total healthcare costs, and we have the possibility of separating these out. But at the end of the day, we are interested in looking for these low-cost interventions to reduce this burdening healthcare debt of our society. And so we are not trying to pull out the mechanism on, for example, we're anticipating the greatest effect is with cardiovascular disease, so we're going to look at certain types of visits or certain types of medications. We're looking at the total healthcare costs. So that is our single variable of interest.
Thank you, Matt. We have a viewer wondering about, you mentioned equity and accessibility to green spaces. So is the outreach material that's being produced going to take this into consideration? So will it be created in a variety of languages with a focus on cultural relevancy? Or how is this aspect of communication being tackled in this particular context?
Yeah, you bet. It sure will be. And that's why many of these partners, on this slide you can see here, we have a group of people exclusively dealing with outreach. Many of these groups are quite interested in reaching out to as diverse an audience as possible. I mean, on a very basic level, producing our infographics and website in different languages. But there's many other ways, there's many other forms of diversity than that. So for example, Highstead Foundation on the left there, actually a grad from Yale FES, he will be helping out with the communication of these materials such that they get to the audiences that we hope they get to. And a lot of that will be through, again, policymakers, I mentioned before, but in particularly these, there's these state forest councils in every state across the nation, and they work with municipal urban foresters. So a lot of that will be through the individuals and the organizations who are actually in charge of developing these green spaces, and many of them are very entrenched and actually part of underserved communities. A great example is the Urban Resource Initiative in New Haven, very much entrenched in underserved communities and very aware of the need to produce materials and to engage with audiences in a way that they feel included and they're part of the process of developing these green spaces. Great question.
Great, thank you, Matt. So it's really great to see that there's all this work being used with the huge amount of data that's provided with the Kaiser Permanente's database. So regarding the current ongoing study and like the timelines that you're thinking of having, when do you expect to have early results? Because it's a very groundbreaking study. So when do you expect to have these early results that can start being implemented through the online platform that you mentioned earlier?
Yeah, so we anticipate some results this fall. They'll be rolling out. We have sort of priority publications and associated materials on the website. And the first ones will be the bigger questions, a central epidemiological study on whether there's an association between green space and healthcare spending, controlling for these confounding factors. Also a return on investment study, which will be looking at how much it costs to maintain these structures related to how much they reduce healthcare savings, such that is it a 1-to-10 weight ratio, is it a 1-to-100 ratio? Those will be top priorities, and we anticipate having results on those in the fall. Looking at different strata and different populations, and certainly building this natural capital project, we're looking at later in 2018 or early 2019.
Perfect, wonderful. So we have actually run out of time. So I would like to thank our three speakers, Kathryn Boyle, Matt Browning, and Stephen Van Den Eeden, for a rich discussion. This recording of the webinar will be available on our YouTube and iTunes channel, so please check back for that. And last but not least, be sure to check out the CBA website and newsletter for more information on upcoming webinars. My co-host, Corey Scalt, and I would like to thank you for joining us for this webinar. Have a great day.